This conference will now be recorded.
Good afternoon. I am continuing the topic corrosive injuries. I think I am in management part. Corrosive injuries. Lead complications are stricture formation, gastric outlet obstruction, esophageal carcinoma, and gastric carcinoma. Stricture formation primarily occurs in the injuries like grade 2B, grade 3, peak incidence in 2 months. These occur as early as in within 2 weeks, as late as in several years after ingestion. Gastric outlet obstruction. The symptoms are early satiety, weight loss, and vomitings. Sir, సోయా సాప్స్ డిశ్చార్జ్ చేసేయండి సార్. అమ్మాయి బాగానే ఉంది. కౌంట్స్ ఒకటి పంపించండి, బ్లడ్ శాంపుల్ పంపించండి, వాళ్ళకి కిందికి దిగిపోమని. అపెండిక్స్ కూడా డిశ్చార్జ్ చేసేది సార్. పంపించేసేయండి సార్. సాయంత్రం వచ్చాక చూసి పంపిద్దాం సార్. అది ఎల్ఎఫ్టీస్ వస్తాయి లోపు. ఓకే. But gastric outlet obstruction is less frequent, which is usually seen after 5 to 6 weeks to several years after ingestion. Usually occurs with acid ingestion. Stomach mucosal injury, stomach injury usually occurs with acid ingestion. Alkali ingestion doesn't cause a relatively less impact on the stomach, because acid alkali reaction will take together and neutralization will occur in the stomach. So impact of alkali in the stomach was less compared with esophagus. Alkali injuries more in esophagus, acid injuries more in stomach, mostly in pylorus part and antrum. Sir, sir. పంపించండి సార్. ఇంక బాగానే ఉందిగా. ఏం పర్లేదు సార్, ఏం పర్లేదు, ఏమవుతుంది. సెప్సిస్ తగ్గింది, ఆటోమేటిక్ కంట్రోల్ లేదు. మన 2.1 2. ఎంత ఉండే కంట్రోల్ లేదు. నాకు కంటిన్యూ చేసేయండి సార్. మండే రమ్మన్నా నేను వాడిని. సార్. Esophageal carcinoma. Incidence of esophageal carcinoma increases to 1000 to 3000 fold. With esophageal carcinoma, 3% have history of caustic ingestion, acid or alkali. Scar carcinoma, after wound healing, there is formation of scar or stricture or stenosis. These are in this area, the esophagus or stomach is less distensible, usually less distensible due to scar formation. If there is any carcinoma, growth occurs at the scar region, so it becomes very difficult to dilate that particular area, causes dysphagia, which usually presents earlier. Initially, whenever there is any scar identified in the esophagus or stomach, which causes symptomatically with dysphagia, we will go for dilatation, endoscopic guided dilatation. If complete stenosis occur, esophagus or stomach doesn't allow the passage of endoscope, then go for recession anastomosis, a bypass surgery, bypassing that particular part. Gastric carcinoma, it is rarely occur. Management part, acute gastric ingestion. First we go for airway management because injury to the larynx, epiglottis, which causes edema, blocks the airway. If any edema is there and patient present with shortness of breath, go for tracheostomy because if edema is there, we go for any intubation. It further damages the mucosa and blocks the tube. Chest and abdominal radiographs to rule out perforation. If perforation is there, then go for early emergency surgery. If there is no perforation, then go for endoscopic evaluation for grading the type of injury, and it is also useful for the further management. Once patient is stabilized on endoscopic examination, there is minimal injury or no injury, then allow the orals within 24 hours. After 24 hours, patient may discharge. And ask for follow-up after 5 days, and then go for repeat endoscopy. Once to confirm the no injury is there is no need of further follow-up. If patients are clinically ill, patient may present with hypotension, respiratory distress. On endoscopic examination, there is grade 2 or grade 3 injuries. They should be admitted in the ICU setup with close monitoring, with prediction of any perforation. Laryngoscopy should be performed in patients with respiratory distress. Patient having any edema or necrosis in the larynx and pharynx should not undergo any endotracheal intubation. Go for tracheostomy to maintain the airway. Interventional or surgical options in acute costic injury. Esophagus or stomach is viable. Go for intraluminal esophageal stent. Or jejunostomy. If there is any doubt in esophagus or stomach injury, we'll go for endoscopy after 24 to 48 hours. Reassess the depth of injury. In reassessment, if there is any necrosis in full thickness, then go for esophagogastric recession because chances of perforation are high. Recovery chances are become poor. Cervical esophagectomy. Jejunostomy. Recession of adjacent involved organs. Prevention of strictures by using steroids. Steroids usually reduce the inflammation by reducing the inflammatory mediators, suppressing the inflammatory mediators. Antibiotics. Open injuries usually very much access to the infective organisms. So by giving antibiotics, you reduce the bacterial count and reduction in the inflammation. Nasogastric tube or Ryle's tube. Useful for the feeding and stenting, bypassing the damaged area. But contributes to the development of long strictures. Routine use is not mandatory. Total parenteral nutrition. This is useful in improving the nutritional status and allows for reepithelialization of the raw areas or injured areas by putting the nil by mouth, giving rest to the bowel, so that which allows the reepithelialization of the raw areas or injured areas. And TPN is also useful by increasing the nutritional status of the patient. It further enhances the wound healing. intraluminal stent. These are useful in the prevention of stricture formation or decreasing the stricture formation by preventing the contact of two raw surfaces in circumferential injuries. And patient condition is not good at that time. If any perforation is there, we will put stent so that it prevents the leakage of contents. This is the self-expanding stent. Self-expanding metallic stent. Early dilatation, prevention of strictures. Early dilatation, less than 1 week. But it is controversial because already there is mucosa is injured and edema is there. There is a chance of rupture while manipulating the dilatation process by endoscopy. But early dilatation usually prevents the stricture formation. This is controversial, depends upon the patient condition and grade of injury. Will go for the dilatation process. Anti-reflux treatment. Empirically used proton pump inhibitors like pantoprazole, omeprazole, H2 blockers like ranitidine, cimetidine. These are useful in reducing the esophageal injury further by gastric reflux. These are the esophageal dilators used in the dilatation of esophagus. There is various sizes. Treatment of strictures. Endoscopic dilatation. Intraluminal stent and surgery. Endoscopic dilatation, the goal is dilate the esophageal lumen to the 1.5 centimeter or 15 mm. Perforation rate is 0.5%. Special considerations in long eccentric strictures, risk of perforation is high, thick walled strictures, recurrence is high, multiple sessions may be required, intraluminal stent, temporary placement of self-expanding plastic stent, surgical management is recession, esophagectomy with colonic interposition, gastric transposition, usually performed 6 months after the process. Indications of surgery: complete stenosis, marked irregularity and pocketing of barium swallow, mediastinitis or severe periesophageal reaction on dilatation, formation of a fistula or perforation, hemodynamic instability with systemic disturbances, there is inability to dilate or maintain the lumen above the 40 French bogey. Bogey is like tube-like material like rice tube. Poor compliance from the patient side. These are all indications for surgery. Esophageal substitutes. Most commonly used is the stomach. After that, colon, either right or left, or ascending or descending. And jejunum. Ideal esophageal substitutes. Technically simple to construct. Minimal incisions. Minimal number of anastomosis. Like esophagogastric or esophagocolon, gastrocolic, colocolic. These are number of anastomosis are there while doing esophageal recession. So esophagogastric is only single anastomosis, but using the colon for the conduit, there are 4 to 5 anastomosis are there. Cervical part, cervical esophagus and colon. Proximally, distally, colon and remnant of the stomach are GE junction of the stomach, and then colocolic anastomosis. To prevent the reflex, go for jejunal anastomosis. So there are, by increasing the number of anastomosis, there is very much high morbidity. So minimal number of anastomosis is the ideal for esophageal substitutes. Adequate length should be replaced, and mostly we'll look for the reliable arterial and venous blood supply. Allows normal swallowing, does not alter the GI function. Usually after surgery there is a change in the GI function, but it becomes to near normal level, come close to the near normal level after surgery. సార్ లేదు సార్ ఇప్పుడే కావలే సార్ ఇప్పుడే సార్ ఒక హాఫ్ అన్ అవర్ ఓకే సార్ resistant to acid reflux, stomach usually secrete acid. After esophagectomy there is loss of lower esophageal sphincter is there, so reflex chances are very much high. So whenever there is any conduit is used after esophagectomy, it must be resistant to the acid reflux. Durable with no long-term complications. Routes of esophageal substitution: posterior mediastinum, short and direct, usually used procedure. Retrosternal, just below the sternum, it is long. Subcutaneous, transpleural, previously any mediastinal surgery is there. Endoesophageal, roll of laparoscopy, rapid assessment of stomach serosa, no recession, go for feeding jejunostomy. If any necrosis is there, go for subtotal esophagectomy and total gastrectomy. This is the flow chart. Corrosive injuries, early admission within 48 to 72 hours. Go for endoscopy. In endoscopy, mild lesions, allow him for discharge, put him in follow-up. Severe lesions in early endoscopy, stage 3, stage 2B, stage 3. Because stage 4 we don't go for endoscopy, we'll directly go for surgery. Stage 4 is perforation. Go for according to the lesion level. Endoscopic dilatation. If any stricture formation is there, delayed admission 72 hours to 3 weeks. No need of endoscopy. If patient present with dysphagia, go for gastrostomy. Endoscopic dilatation if needed after 3 weeks of ingestion. Late admission after 3 weeks. Endoscopic dilatation, if it is successful, follow up for after 1 month. Unsuccessful, surgical gastrostomy and retrograde dilatation after 10 days. Conclusion, signs and symptoms alone are not reliable to guide the injury. Early endoscopy has a crucial role. Grading and manage appropriately. Surgical treatment is good option in patients with severe strictures. Colonic interposition might be the best surgical procedure. Thank you. Put your attendance in the chat box. Thank you.